Module 5, Procedures and Treatments. Nurses have to follow guidelines that are set by healthcare institutions. Appropriate preparation needs to be done before the procedure. We need to follow up appropriately once the procedure is complete. And the nurse is responsible for the client's safety before, during, and after all procedures and treatments. Supporting the child and family is important for the role of the nurse. We also need to follow the facility's policies to ensure that legal requirements and safety precautions have been met. In addition, we need to play psychological and emotional support. The nurse does this through comfort. We are an important source of comfort. So it's really important to explain the procedure and the purpose to the family and child in an age-appropriate manner. We also need to listen to the child and answer any questions that the child has in addition to the family member. Take charge in a kind, firm manner when they're too young to take responsibility for themselves. As far as those legal and safety factors, most procedures are going to require a written order prior to being done, and clarify orders as needed. Make sure we always properly identify the child using those two methods, and complete an informed consent if it's necessary. Hand hygiene is a big must. Gather supplies and follow the standard precautions. As far as follow-up for procedures, when those procedures are done, leave the child in a safe position. We may have to leave some of those side rails up with the bed lowered and the call light within reach. That should be a given. Address concerns and questions of the family. Remove all equipment and supplies that are no longer necessary, dispose of them, or uh, move them per facility policy. Take care of contaminated linens. Properly label any specimens and take them to the lab. Complete all that necessary paperwork documenting everything. And definitely follow the facility's policy concerning giving the child a reward after a procedure. So question. Whoops, I went a little bit too far, but let me ask the question. Before performing a procedure, the nurse must validate the child's identity. You can do this by simply asking the child's name. And we know that that is false. We have to have two identifiers, just as we would if it were an adult. I want you to look at these pictures here. In the first picture, we have a mummy restraint. These are some of the different restraints that we may use with children. We also have the papoose board, which will also restrain a child's arms and legs. We can leave the necessary extremity available, or if it's their head is already available. We have the clove hitch restraint, which will limit movement of an extremity. Then we have a couple of elbow restraints. And finally, we have a jacket restraint, which will prevent a child from climbing out of a bed or a chair. And then the crib top restraint, which prevents the child from actually getting out of the crib. They're little Houdinis and they can find a way out of most everything. As far as using restraints, understand they might be required to protect a child during a procedure or an exam, and it can be very difficult to see a child restrained. So we use this as a last resort and never use it as punishment. Follow the healthcare facilities and Joint Commission's guidelines. Again, this might require a written order or a set procedure that we have to follow. If these restraints are to stay in place, then we need to release them every couple of hours, doing range of motion, monitoring circulation and neurovascular status, and documenting all those findings just as we would if this were an adult. And in those cases also, that order has to be renewed every 24 hours. Certain situations are going to require mechanical restraints. We need to be alert to the family concerns, and in some cases, the family might be able to help by restraining the child with their hand. Close observation will be required for every form of restraint. When a child needs to feel safe and secure, holding is one of the best methods to provide that security. Some of the common methods of holding an infant, for example, would be the cradle hold, which is in the right lower left, the upright over the shoulder, which is in the lower middle, and the football hold, which is in the lower right. Excuse me. And there's a variety of positions for burping also. The picture on the top shows sitting an infant up to burp them, but we can also put them over our shoulder as long as we're putting pressure on their tummy, because that's what we're trying to get the bubble from. When we're transporting, this is a big safety concern. We should place an infant in a crib or a bassinet to transport. A toddler should be placed in a crib with high side rails or a high-topped crib. Strollers and wheelchairs can be used when the child's able to sit up. We can also use wagons with high sides available. Older children can be placed in wheelchairs or stretchers or moved in their own bed. We do need to consider using safety belts or seat belts to prevent the child from falling out. We also need to position the child for sleep, especially our infants. They need to be placed on their back for sleeping. This position has significantly decreased the incidence of SIDS, or sudden infant death syndrome, and reinforce this information with family caregivers. So when we're performing procedures that are related to elevated body temperature, we need to be aware, of course, what the normal temperatures are. And they're pretty much the same as they would be for an adult. Body temperature should generally be maintained below 101 orally or 102 rectally. We don't recommend the tepid baths for a child to reduce fever. There are some different things we can do though, such as not overdressing or covering the child with multiple blankets, encouraging that child to drink fluids, keeping the room environment cool. Using acetaminophen or other antipyretics as directed by the healthcare provider, but we should never give a child younger than 12 aspirin. And retake the temperature again in about 30 minutes to see if there's changes. If the temperature is above 105, always call the healthcare provider. Or if the child has a history of febrile seizures. We need to control those environmental factors that we are able to. Remove excess coverings will permit additional cooling through evaporation, lowering the room temperature, applying cool compresses to their forehead. But if the child begins to shiver, we have to stop that cooling method, because the shivering is actually going to increase their metabolism and cause their body temperature to go up. There are some cooling devices that are available, such as a hypothermia pad or blanket to lower or maintain a body temperature, but it's really important to closely monitor the child's temperature and, of course, always document the procedure. So another question. When lowering a child's temperature and shivering occurs, you must stop what you're doing to lower the temperature, because this is because shivering does what? This is the body's mechanism for raising the temperature. With intake and output, it's important to accurately measure eyes and nose to ensure adequate fluid balance, as it is with anybody. Always describe and record the color and characteristic of the output as well as the amount, and use the appropriate equipment to measure. With infants, we can always weigh wet diapers and compare that weight to a dry diaper. With enteral feedings, this is how the infants can or child can receive nutritional needs through a tube feeding. We can do gavage feedings where the tube is passed directly into the stomach through the nose or the mouth. This can include bolus feedings where we do intermittent feedings, continuous feedings where we regulate the flow rate, attach it to a feeding pump. We could also give feedings during the night so the child can be detached during the day. We should always aspirate the amount remaining in the stomach to determine how effective that treatment was. With gastrostomy feedings, this is a feeding done through a tube that's inserted into the abdominal wall going into the stomach. These are good tubes if feeding tubes are needed for a long period of time. They're usually inserted surgically under general anesthesia. That site has to be kept clean and dry, and we have to monitor for signs of infection and irritation. The child may need to be restrained to prevent pulling on that tube. Gastrostomies are often used with conditions that will interfere with the ability to eat or drink, surgical repairs in the mouth, swallowing issues, throat or esophageal concerns, severe gastroesophageal reflux disease, respiratory distress, or respirator dependent children. A gastrostomy button may be inserted for a long-term gastrostomy feedings, and then it can be surgically removed when it's no longer needed. Make sure that you always maintain the proper position when feeding a child through a tube. Flush the tube after every feeding to make sure it remains patent. Again, preferable to have the head of the bed elevated approximately 30 degrees to allow gravity to help with digestion of those feedings. So question, before beginning a gavage or gastrostomy feeding, it's necessary to check the placement of the tube. What method of tube placement is considered unreliable? Is it inserting air into the tube and listening for the sound? An X-ray to check placement? Aspiration for stomach contents? Or asking the client to talk? It's inserting air into the tube and listening for sounds. So with oxygen administration, this is administered to treat symptoms of respiratory distress or below normal oxygen saturation levels. The delivery method will depend on the child's age and their oxygen needs. Make sure you explain the procedure and the equipment to the child and family member. Let the child hold and feel the equipment, the flow of oxygen through the device. We really need to closely monitor children who are receiving oxygen therapy. Check that equipment frequently to ensure proper functioning, cleanliness, and correct oxygen contact. Exposure to high levels of oxygen can be very dangerous for kids. Reinforce teaching with family caregiver if the child is to receive oxygen at home. So, oxygen safety methods, we need to keep the equipment clean because dirty equipment is a source of bacteria. Use signs noting that oxygen is in use in the room. Give the child good mouth care and keep their nose clean. Offer fluids frequently. Do not allow the use of electric or battery-operated toys, smoking, matches, or lighters anywhere near oxygen because it does support flame. And keep flammable solutions. Um, it says keep flammable solutions in the room. I'm not sure why we would do that. Use wool or synthetic blankets. Oh, yeah, we do not want to keep flammable solutions in the room, and we should not use wool or synthetic blankets for the simple fact that these can support flame. As far as nasal and oral suctioning, if an infant or child is unable to cough to clear their airway, secretions are removed by suctioning. We can do this with a bulb syringe. Sterile normal saline drops might be used to help loosen dried secretions. Nasotracheal suctioning can be done with a sterile suction catheter to also help remove secretions. Tracheostomy care. Sometimes a child may require a surgical procedure to place a tube in their neck to provide a patent airway. This might be temporary or permanent, and then we definitely would remove secretions by suctioning. It requires proper care of the site and tracheostomy tube, and if the child is to go home with the tube, we definitely need to teach the caregiver uh, how to take care of this. If the child is unable to cry or speak, they need careful monitoring. So make sure you leave that call bell within reach or find alternative methods of communication. And always keep a spare tracheostomy at the bedside in the case of accidental dislodgement. Now, these two slides show the reason we might want to use a particular method of oxygen administration and different concerns that we may need to use when using oxygen. It does say here that when we use the nasal prongs or cannula that oxygen is not humidified. We have a concern if it's not humidified. So we need to always, always, always humidify the oxygen that a pediatric client would receive. So heat therapy increases circulation by vasodilation and promotes relaxation of the muscles. It speeds formation and drainage of superficial abscesses. It does require a specific order to apply artificial heat to a child's skin. We can do this through dry heat or the electric heating pad or a K-pad. Proper procedure and documentation is always necessary, and we need to monitor for safety, making sure that the child doesn't receive any burns. Cold therapy also requires an order from a healthcare provider. It helps reduce body temperature, preventing swelling, controls hemorrhage, and can provide that anesthetic effect. We do need to understand that intervals of 20 minutes of dry cold or moist cold is what's recommended because after 20 minutes, it really doesn't do any good. So up to 20 minutes, it can be very beneficial, but after 20 minutes, take it off. We need to protect the skin from direct contact, so always have a layer between the skin and the cold source. Inspect the skin before and after application. These kids are at a risk for frostbite and gangrene. And then, of course, always document the procedure. As far as enema administration, occasionally we do have to give enemas to children. It is uncomfortable and it's threatening, and we have to discuss this with the child prior to giving the enema. The type, amount of fluid, distance the rectal tube is inserted will vary according to the child's age. Of course, we always lubricate the tube prior to insertion into the rectum and never force it. If resistance is met, the tube should be removed and we need to contact the healthcare provider. We should hold the buttocks of the infant or the young child for a period of time to help make sure that that fluid stays in place. And then we instruct the older child to hold the solution. Excuse me. Have a diaper or a bedpan available prior to starting. As far as ostomy care, children can have the same types of ostomies that adults have, whether it's a colostomy, ileostomy, urostomy. The care of the ostomy will depend on the type. They also will have those collection bags to collect drainage, and skincare around the stoma is very important. Always check those ostomy bags for leakage, empty them frequently, and change the bags when necessary. And of course, record output. And as always, there's a lot of different appliances available. Another question, true or false? It's very important for the nurse to ensure the family caregiver completely understands the need and carefully pick up the young child's toys who will be going home with the tracheostomy and receiving oxygen supplementation. True. As far as collecting specimens, nose and throat specimens will be used to diagnose infection. Nasal washings can be used to diagnose RSV. Swab the nose or the back of the throat, tonsils with a special collection swab. That swab will be placed into a culture tube, taken to the lab for analysis. But don't obtain a throat culture if glottitis is suspected due to the high risk of possible trauma and airway occlusion. To obtain a urine specimen from an infant, after cleaning the perineal area, we'll place cotton balls near the urethra, excuse me, and replace the diaper. After voiding, we can squeeze the urine out of the cotton balls and use the collected urine to test. With toddlers and young children, give them some fluids about 15 to 20 minutes before that urine specimen is needed. Provide the older child and the adolescent privacy when collecting the specimen. We can do a clean catch where we collect that midstream specimen, or catheterize the child when a sterile specimen is required. The type of equipment will depend on the situation, and it can be an in and out, the straight cath, or an indwelling catheter. With the 24-hour urine collection, empty that bladder initially, as we would with an adult. Collect all the urine that's voided in the next 24 hours and keep that urine on ice in a special container. Then we send it to the lab at the end of 24 hours. If any urine is accidentally discarded, we have to start over. The picture on your slide shows the collection of a urine sample from an older child, maybe a toddler, where we place an adhesive bag over the meatus to collect the urine. With a stool specimen, we might be looking for occult blood, ova and parasites, bacteria, glucose, or excess fat. We can use a tongue blade to collect the specimen from a diaper or bedpan. It should not be contaminated with urine. And as always, we label and deliver it to the lab as soon as possible. Document the time, the stool color amount, the consistency, the odor, the test that's to be performed, and the condition of the child's skin. The LPN has to be familiar with collecting blood from a child so they can assist. They may be asked to help hold or restrain a child during the procedure. Blood obtained either by pricking the heel, the great toe, the earlobe, or the finger, or venipuncture. Infants, sometimes we will use the jugular or scalp veins more frequently. Older children, we can also use the veins in the arms. The child's not going to understand what is happening when we want to do a lumbar puncture. And it's very important to tell the child to hold still. Restrain the child in an appropriate posture. We need to kind of bow that back outwards to help separate the vertebrae. This procedure is performed with strict asepsis, and we apply a sterile dressing after the procedure is complete. The child must remain quiet for an hour after the procedure in a supine position. And at that time, we'll be monitoring vital signs, level of consciousness, motor activity frequently for several hours after the procedure. Various other departments are going to perform diagnostic tests and procedures, and they can include x-rays, arteriograms, CT scans, IVP, bone or brain scans, ECG, EEG, MRI scans, and cardiac catheterizations. The nurse's role will be to reinforce teaching and prepare the child and family caregivers for the procedure. We should request and schedule tests or studies after receiving written orders from the healthcare provider and ensure that required paperwork and informed consent has been completed. Ensure that proper pre-procedural steps are completed, such as being NPO, medication has been given, enemas have been done, etc. Clarify and document any allergies on the consent and requisition forms. The nurse may be called on to support and comfort or restrain a child during a procedure. Always ensure that proper documentation is completed after the procedure and provide any post-procedural care. Question: true or false? At the conclusion of any procedure, the nurse should ensure all documentation is completed as per the facility or agency policies. Most definitely. So now time for your post-test.